Hello everyone, so our case for this case study is about thyroidectomy. So our admitting diagnosis for this is hyperthyroidism due to toxic multinodular goiter. So it is a condition in which multiple thyroid nodules produces excessive thyroid hormones leading to an overactive thyroid gland. So the proposed surgery for this is a subtotal thyroidectomy. A subtotal thyroidectomy is a surgery where most of the thyroid gland is removed, but a small part of it is left behind. This is done to reduce the amount of thyroid hormones being produced while still allowing the gland to work a little. The goal is to treat the problem without completely removing all the thyroid function. So this is done wherein a surgeon makes a small cut across the lower part of the neck, which is a polar incision, and they carefully separate and remove the enlarged part of the thyroid gland while protecting important nearby structures like the parathyroid gland and the recurrent laryngeal nerve, and ensuring that the surgery is safe and avoids complication. The surgical position appropriate for this is a supine with neck hyperextended or a semi-Fowler position. So it is appropriate because it provides optimal access and visualization of thyroid gland for safe and precise surgery. The nursing responsibilities for this surgical position is first, to place a roll under the shoulder to extend the neck appropriately. Second is to ensure proper alignment to prevent nerve or muscle injury. Third is to pad all bony prominences to prevent pressure injuries. And lastly is to monitor the patient's position throughout the procedure to maintain stability and comfort. The type or site of incision for this procedure, which is thyroidectomy, is a polar incision, and this incision is made transversely along a natural skin crease approximately 2 to 4 centimeters above the sternal notch in the lower anterior neck. It typically measures around 4 to 6 centimeters depending on the size of thyroid gland and the surgical exposure required. The skin preparation for thyroidectomy is first to begin at the surgical site and extend the preparation up to the chin, down to the upper chest, and to the both sides of neck, including the sternal cladomastoid muscle. You should use a circular motion starting from the incision site and work outward, ensuring a thorough antisepsis. So the type of anesthesia appropriate for this procedure is general anesthesia. The anesthetic agent are propofol for induction, sevoflurane for maintenance, and remifentanil for analgesics. The nursing responsibilities for this type of anesthesia and agent is first to confirm fasting and ensure that informed consent is completed. Second is to prepare all required airway management equipment. Third is to monitor vital signs during anesthesia and note any adverse reaction. Record the type and dosage of anesthetic agent used. And lastly is to assist in patient recovery post-anesthesia by monitoring for respiratory distress or nausea. These are the types of regular instrument used, which are the scalpel, the Kelly, forceps, needle holder, and retractor. The special instruments used are nerve stimulator and Leakey thyroid grasp. So here are the appropriate suturing technique for different types of tissues and the appropriate size and name of suture.
Immediate post-operative nursing care. Patient's problem and nursing intervention. Problem number 1. Risk for respiratory distress due to potential airway and obstruction or laryngeal nerve damage. Number 1. Monitor for signs of airway obstruction such as stridor, difficulty of breathing, or increased respiratory effort. These signs indicate possible compression or swelling in the airway. Number 2. Position the patient in semi-Fowler position to promote optimal lung expansion and ease breathing. This position helps prevent post-operative edema from blocking the airway. Keep emergency airway equipment available at the bedsides, such as tracheostomy kit to ensure quick intervention in case of severe airway compromise. Number 4. Assess for hoarseness or changes in voice quality, as this may indicate damage to the recurrent laryngeal nerve. If this occurs, report findings to the surgeon or further evaluation. Rationale. The thyroidectomy procedure carries a risk of airway obstruction due to post-operative swelling or inadvertent injury to the airway structures. The early identification of airway problems and proper position can reduce respiratory distress. Number 2, hypocalcemia due to inadvertent damage or removal of the parotoid glands. Number 1, monitor for symptoms of hypocalcemia such as numbness, tingling of the lips, hands, and feet, or such as muscle spasms. Pay particular attention to chopstick signs and Trousers signs. Check serum calcium levels as ordered by the physicians to identify any early signs of hypocalcemia. It is crucial to monitor calcium levels, particularly within the first. Number 3, administer calcium supplements such as calcium gluconate intravenously if hypocalcemia is detected. Administer oral calcium supplements post-discharge as prescribed. Rationale: the parotoid glands responsible for regulating calcium levels can be affected during thyroidectomy. Hypocalcemia is a common complication after thyroid surgery, leading to symptoms such as muscle cramps and spasms. Early identification and treatment of hypocalcemia are critical to preventing severe complications. Problem number 2, risk for hemorrhage due to vascular nature of the thyroid gland. Observe the surgical site for swelling, bruising, or visible bleeding. Note any increase in neck circumference or tightness, as this may indicate hemorrhage or hematoma formation. Number 2, monitor vital signs carefully, especially blood pressure and heart rate, for signs of shock such as hypotension and tachycardia, which may indicate blood loss. Number 3, monitor surgical drains. For any excessive drainage of blood or fluid, record the amount and nature of the drainage regularly, as significant bleeding may require prompt surgical. Number 4, apply pressure dressing and ensure proper bandaging to minimize blood loss at the surgical site. Rationale: the thyroid gland is highly vascular, so the bleeding is a common complication following thyroidectomy. Close monitoring for signs of hemorrhage along with early intervention. It is crucial for preventing severe blood loss and possible shock. Problem number 4, pain related to surgical incision and tissue manipulation. Attentive to any signs of discomfort or distress such as grimacing or restlessness, especially in the first 24 hours of post-surgery. Administer prescribed analgesics such as acetaminophen or opioids. Based on the severity of the pain, consider using multimodal approach to pain management. With non-opioids to reduce opioid usage. Encourage relaxation techniques such as deep breathing and exercise or guided imagery to help reduce the pain, perception, and anxiety. Monitor for side effects of analgesics medication, including sedation or nausea, and take corrective actions such as necessary. Rationale: pain is a common post-operative concern after thyroidectomy due to the incision and manipulation of tissue. Proper pain management is essential to ensure the patient's comfort and facilitate early mobilization. A comprehensive pain management plan helps prevent complications such as prolonged immobility and deep vein thrombosis. Problem number 5. Number 1. Assess the surgical site or any signs of infection such as increased redness, swelling, warmth, or drainage. Note any unusual discharge or signs of delayed wound healing. Monitor vital signs for fever, which may indicate an infection. Administer antipyretics as ordered to manage fever and discomfort. Number 3. Provide proper wound care. Ensure that the surgical dressing is intact and dry. Reinforce the dressing as needed and educate the patient about keeping the area clean and dry. Administer antibiotic as prescribed to prevent infection, especially if there is suspicion of contamination during surgery or if the patient has an underlying condition that increase infection risk. Rationale: surgical site infection are significant concern after any surgery, including thyroidectomy. Proper wound care and timely intervention can reduce the risk of infection and improve healing outcomes.